can see, the previous speaker, he is on this list of authors or people behind the ideas of this study. So anyway, the second man is a guy who used to be an infectious disease specialist at the most prestigious infectious disease clinic in Stockholm, Karolinska Institute, and after that he was converted to become a GP 12 years ago. He's now 65 years old or young, young. And the third person is the chief financial officer of the region in which this study took place. And Shlomo, you all know. Anyway, I agree with Shlomo that age is just a number, isn't it? So, and also, I mean, my grandfather, when he was 60 years old, he was, you know, actually at the age of 50, the normal present to give a person with the age of 50 was a stick, a silver stick, a wooden stick with a silver clutch. Well, I'm 60, well, I need a crutch, but so this is the context of this study. Is Sweden, and this is, as you can see here, this is the country, and surrounded by the Baltic countries and Norway, UK, etc. So now you have the position, and there is a small island in the Baltic. You see it enlarged here. This is where I live actually, and I'm now a professor of family medicine in this town, which is the hospital. Oh. The hospital of this region sits in this town. This is Kalmar. And Öland is the island. And the northern part of Öland is Borgholm. And in Borgholm, there is a population of 11,000 people. In the summer, 300,000. So you can understand it's a vacation spot. But in the winter time, it has been very dead before this man, Åkesson, the infectious disease specialist, he came there a few years ago, and he tried to change things. There is a 6-kilometer bridge connect between Kalmar and Öland, so it's only 52 years old. So many of the older people in Öland, they consider it as if you have a day off the island, it's a lost day to them, you know, because they want to stay where they belong in their rural surroundings. Anyway, as you said before, geriatric care needs are increasing in Europe, also in Sweden, of course. I think I tell you that the Borgholm municipality, I will give you numbers of, it's almost the same number of percent of people aged 75 plus than 65 plus in Spain. So you can imagine this is a very old population, almost like Ferdinando's maybe in Italy. So, and there had been difficulties recruiting primary care physicians in rural areas all over Europe, I think maybe all over the world. And this has resulted in high elderly hospital care use. No surprise. So the research question in this project, could a new model of geriatric care decrease the hospital care needs in Borgholm as compared to the rest of the region? The Kalmar region, which is populated by, I didn't show you that, 225,000 people live there. And could this be done without adversely affecting mortality? And that's where Shlomo comes in. He posed the right question. Okay, you can decrease hospital care needs, but what about mortality? Because there are projects where, you know, you don't allow them to get into the hospital. And then, of course, they might die more. I don't know. It's dangerous to go to hospital. Of course, you can get you know, fall injuries and infections. But very good question by Shlomo. That's why he's on board this project, and to help us. So a new model of care, the home hospital care, was developed in Borgholm in 2016 to 2017. One big thing was to limit the list size of the PCPs, of the primary care physicians, to 1,000 patients. Another thing was to have daily slots in the schedule for primary care physician home care visits bookable by community nurses, ambulance nurses, and PCPs. And they had daily anticipatory care planning contacts with the Kalmar hospital staff. So they had contacts to, you know, to communicate with the hospital nurses and physicians. That was also a new thing. And also the ambulance staff were allowed to, or were encouraged to, make home visits and take blood tests and, you know, measure oxygen saturation in blood, etc. Also, there was a home e-monitoring of heart failure patients included in this project. So it's quite a large number of variables here. Also, they have a regular referral letter conference with all primary care physicians in Borgholm. Every week they meet together and discuss the referral letters before they send them to the Kalmar hospital. So the method to evaluate this was to use just ordinary care statistics done by the chief financial officer, Joachim, the third person in this project. And also, thanks to Shlomo, we did comparison of official mortality statistics from Statistics Sweden, which are quite good actually. So this is to illustrate the daily slots for home visits for all PCPs, often together with community nurses. So this is a home visit by one of the doctors in Borgholm. Also max 1,000 patients listed per primary care physician. This is Åkesson, the guy, 65-year young, formerly infectious disease specialist, now converted to general practice or primary care. Great guy. They have the best equipped ambulances in Sweden. I learned this summer when I visited the island. And I said, as I told you, ambulances make home calls to check vital signs and take blood tests. Also, this happy Greta, she's home monitoring her heart failure. So she regularly, registers data on her weight, on her well-being, on her maybe heart rate and oxygen saturation. But I think that the most important variable here is how are you feeling today? Are you okay or not? So the nurses sit in the other end of with a computer and check on Greta, and if there is something wrong, they phone her and they check her. Maybe adjust the medication, the diuretics, and so on. So this is the picture from the weekly referral letter conferences with all the primary care physicians at Borgholm Primary Care Center, and they have a satellite care center also participating here on Skype or Zoom or whatever. So there are quite a number of physicians going through all the referrals. Is this a necessary referral? Could we do something else than refer? And so they are very happy at Kalmar, the other end, to receive these well-thought referral letters. Okay, this is a secret weapon, I think, in this, which I discovered when I visited the health center at Borgholm in March. Those of you who read Swedish know what this means. You can figure it out. Who figures this out? What kind of machine is it? Can you read from? No? Those of you who have sharp eyes. Okay, I'll give you a clue. Up here, it says yogurt, and soft ice. Cream freezer. And okay, this is Gova, gift to the staff, the doctors. So this secret weapon, altruism, I think, important. Anyway, the results. Okay, so how did the statistics go? Between 2014, before the project started, and 2018, when it had been running for a few years. And this goes for only patients or persons 75 years and older. So there was an increase in home care with 70% in Borgholm, not surprisingly, but it decreased by 2% in the rest of the region. There was a total care consumption decrease of 4% in the Borgholm municipality, but an increase by 10% in the rest of the Kalmar region. There was an emergency room visit decrease by 19% in Borgholm, an increase by 9% in the rest of the Kalmar region, and hospital care decreased 7% in Borgholm, increased 13% in the rest of the Kalmar region. And hospital outpatient visits also decreased in Borgholm, whilst it increased by 21% in the rest of the Kalmar region. So this seems quite impressive. But then comes the question from Shlomo, how did it go with the mortality? Now it comes the critical result here. So, well, actually total mortality decreased from 7.4 to 6.8% in the Borgholm region. This goes for the annual mortality for people 75 years and older, and it decreased from 7.4 to 7.2 in the rest of the Kalmar region. So there was a slight difference, but the most important thing is that it didn't increase, at least in the Borgholm region. Then, of course, I also did try to compare it with the secular trends in the rest of the Sweden, in municipalities of almost the same size as Borgholm, and it showed that the median mortality in 27 municipalities that were about the same size as Borgholm, from north to south, the mortality was 7.4% in 2014 and 7.2% in 2018. So the conclusions are that a new geriatric care model of comprehensive collaboration between the strengthened primary care and community care, hospital care and ambulance care, for Clover, you could see, or at least if you're not counting the hospital care, a trinity between primary care, community care, and ambulance care, they call it themselves. This trinity was associated with a reduction in total care use for seniors in a rural Swedish jurisdiction. And during the time of the intervention period, age-specific mortality did not seem to be affected negatively in the intervention area. Okay, so thank you so much. Points for discussion are, could this care model be exported? If not, what are the obstacles? Would you like to work as a primary care physician in such a care model? Thank you.